Welcome to the deep dive. Today, we're taking a close look at something really vital in equine health, atrial septal defects,
Yeah.
ASDs for short, in horses.
Mm-hmm.
Think of it as our deep dive into holes in the heart, really exploring what these congenital conditions are, how they affect these, well, magnificent animals,
Yeah,
and crucially, what it means for their health, their potential.
that's exactly right. And our goal here, for this deep dive is really to pull out the key bits from veterinary consult notes, research papers, basically translate that complex medical stuff into clear, actionable insights for you.
Right.
We want to give you a really solid understanding, from the basic definition right through to the more subtle implications for a horse's life. Help you navigate this sometimes daunting information with a bit more confidence.
Okay, perfect. Let's unpack this then at its most basic level.
Yeah.
What exactly is an atrial septal defect?
So put simply, an atrial septal defect is a congenital malformation. That means it's something the horse is born with. And it's essentially a hole in the interatrial septum that's just the wall separating the two upper chambers of the horse's heart, the atria.
A hole in the wall. Got it. And are all these holes created equal, or do they differ?
They definitely vary. The main way they differ is by location. Vets classify them into a few types. There are atrium primum defects. They're lower down, sort of adjacent to the ventricular septum.
Okay.
Then you have atrium secundum defects. These are actually the most common type, found kind of in the middle in the area of a fetal structure called the foramen oval.
Ah, okay. I was going to ask about that name.
Yeah, we'll get back to that. And finally, there are sinus venosus defects, which are right at the base of the septum, often near where the big veins, the vena cava, enter the heart. Now, while these classifications are important for vets to pinpoint things, for you listening, the key takeaway is probably that an ASD isn't just a hole. Its specific location, and maybe more importantly, its size, which we'll talk about, can really change how it affects the horse.
Right. Size matters here.
Exactly. And it's also worth mentioning, sometimes an ASD occurs all by itself, but sometimes it's part of a more complex set of heart problems.
Okay. You mentioned that common type, the secundum defect, is near something called the foramen oval. That sounds important. What is that? What does it do in a foal?
Yeah, the foramen oval, it's actually pretty fascinating. It's a completely normal opening, like a little slit, that every single fetus has between the atria.
Oh, okay. Normal in the fetus.
Totally normal. Its job is to let blood bypass the lungs before birth because, they aren't working yet. Blood goes straight from the right side of the heart to the left.
Makes sense.
Then, once the foal is born, takes its first breath, this opening should functionally close pretty quickly, usually within, say, 24 to 48 hours. Anatomical closure, like fully sealed, might take a bit longer, maybe up to 9 weeks.
So what happens if it doesn't close?
Well, if it fails to close properly, that's what we call a patent foramen oval, or a PFO. And essentially, it acts just like a small ASD. We actually see PFOs pretty commonly in newborn foals. The good news is, many of them just close up on their own within a few days or weeks. No intervention needed.
So a PFO is one potential cause of an ASD if it doesn't close. Are there other ways these defects happen in horses?
Yeah, besides that failed closure of the foramen oval, the other main cause is just a straightforward malformation during the heart's development in the fetus. Something goes slightly wrong in the formation of that dividing wall.
And genetics. Any role there?
Well, we suspect genetics might play a part in some cases. It's known to be heritable in some other species.
Right.
But in horses specifically, it hasn't really been definitively pinned down yet. Overall, though, ASDs are considered pretty uncommon as isolated defects in horses. Less common than some other heart issues.
Okay, so let's get to the impact. When there's this hole in the heart, what does that actually do? What happens inside the horse's body?
Yeah.
This is where it gets really interesting, understanding the consequences.
Right. So because there's this hole, and because pressure is normally higher in the left atrium than the right, blood starts shunting or flowing across that hole from left to right, from the high pressure side to the low pressure side.
And that causes problems.
It does. It creates what we call a volume overload. Basically, too much blood ends up circulating through the right side of the heart specifically. It affects the left atrium, the right atrium, and really importantly, the right ventricle.
Okay, overloading the right side.
Exactly. And the size of that hole, the ASD, directly dictates how bad this overload is. A tiny hole, maybe not much impact. A big hole, a lot of extra volume.
And over time, what does that overload lead to?
Well, over time, this constant extra volume can stretch the heart muscle. In particular, it can stretch the opening of the tricuspid valve. That's the valve between the right atrium and right ventricle.
Oh, okay.
And when that stretches, the valve doesn't close properly anymore, so blood starts leaking backward through it. We call that tricuspid regurgitation.
Like valve.
Precisely. And as that regurgitation, that leakage gets worse, pressure starts building up in the right atrium. And eventually, that backup of pressure leads to the signs of right-sided congestive heart failure, CHF.
Wow. Okay. That sounds quite serious.
Mm-hmm.
Are the signs always really obvious then, or could a horse have this, maybe a smaller one, and the owner wouldn't even realize?
It varies hugely, really a massive range. Horses with small defects, they're often completely asymptomatic, no signs at all.
Really?
Yeah, they might only get picked up by chance, during a routine vet check or maybe a pre-purchase exam. And these horses, often they can live a totally normal life, normal activity levels.
But the larger ones?
Larger defects, that's a different story. They can cause significant problems. An owner might notice things like exercise intolerance. The horse just can't perform like it used to, or maybe just seems generally sluggish.
Okay, performance issues.
Yeah. And then you might see those signs of CHF we mentioned, things like jugular venous distension. That big vein in the neck looks bulging, maybe even pulsing.
Right, I've seen that.
Or peripheral edema swelling, usually in the lower limbs or under the belly. Sometimes even ascites, which is fluid building up inside the abdomen.
Any breathing issues?
Yes, definitely. Things like tachypnea, just breathing faster than normal, or dyspnea, which is actual difficulty breathing, maybe even some coughing.
Mm-hmm.
In foals, especially with larger defects, you might see stunted growth, or they just don't thrive, poor body condition.
Okay.
And in really severe cases, though it's less common, you could potentially see cyanosis. That's a bluish tinge to the gums or mucous membranes. That happens if the pressure on the right side gets so high that the shunt actually reverses and poorly oxygenated blood mixes into the main circulation, but that's quite advanced.
Got it. And what about heart murmurs? Do they always have a murmur if they have an ASD?
Often, yes. A heart murmur is frequently present. Usually it's described as quite a distinct sound, maybe coarse, sort of band-shaped or ejection-shaped, often heard loudest over the pulmonic valve area on the left side.
But not always.
Not always, no. The intensity can really vary. And sometimes, especially with smaller defects, a murmur might be very faint or maybe even absent altogether. It's not a perfectly reliable sign on its own.
Okay.
And with the larger ASDs, you might also hear or detect arrhythmias, irregular heartbeats, things like premature beats, or sometimes even atrial fibrillation, AFib.
Right. Are there any known risk factors? Like, what makes a foal more likely to be born with one of these?
Yes, there are a few identified risk factors. Things like being born premature seems to increase the risk. Also, foals that have a neonatal pulmonary hypertension, that's high blood pressure in their lungs right after birth.
Okay.
And also foals that suffered from neonatal respiratory distress syndrome. Those conditions seem to be associated with a higher likelihood of having an ASD or maybe a PFO that doesn't close properly.
Okay, that makes sense. So given that the signs can be so variable from nothing at all to severe heart failure, how do vets actually pin this down? How do you diagnose an ASD?
It's usually a step-by-step process. It starts, of course, with the clinical history, what the owner has observed, and a really thorough physical examination, looking for any of those signs we just talked about.
Listening carefully.
Absolutely. Auscultation, listening to the heart with a stethoscope, is key. Trying to detect that characteristic murmur, noting its timing, loudness, location.
Okay, what next?
Beyond just listening, other tools come into play. An ECG, or electrocardiogram, can be useful. It looks at the heart's electrical activity. It might show signs of atrial enlargement, or it could pick up those arrhythmias like AFib, especially persistent AFib in some cases.
Right. What about imaging? X-rays.
Radiography.
Yeah, X-rays of the chest. They can sometimes help. With large shunts, you might see signs of increased blood flow in the lungs, what we call increased pulmonary vascularity, or maybe evidence of heart enlargement. Signs of pulmonary edema if heart failure is present.
But, I sense a but. Well, the but is that getting really good, clear, diagnostic quality chest x-rays in a big adult horse can be technically quite challenging. You need powerful machines, and interpretation can be tricky.
Okay, so maybe not the first go-to for a definitive answer.
Exactly. It can provide clues, but the absolute gold standard, the definitive diagnostic tool, is echocardiography.
Cardiac ultrasound.
Precisely, cardiac ultrasound. This lets vets actually see inside the heart in real time.
What can you see with it?
You can directly visualize the defect itself, see its location, measure its size. We look for something called atrial septal dropout on the image, which is basically the hole, and crucially, we confirm it by looking from different angles, usually two perpendicular planes to be sure it's real.
Okay.
Echo also clearly shows the consequences. You can see if the atria and the right ventricle are enlarged or dilated because of that volume overload. The right ventricle often takes on a more rounded appearance.
And the blood flow. Can you see the shunt?
Yes, absolutely. That's where Doppler echocardiography comes in. It uses sound waves to visualize blood flow. You can actually see the jet of blood moving from the left atrium to the right atrium across the defect. It's very characteristic.
Wow.
And in certain situations, like if we're worried maybe the shunt is going the other way, right to left, or if the defect is hard to see directly, we might do a contrast echocardiography. It's often called a bubble study.
Bubble study.
Yeah, you inject a sterile saline solution that's been shaken up to create tiny microbubbles into a vein. Then you watch on the ultrasound. If you see those bubbles appearing in the left atrium shortly after injection, it confirms there's a shunt allowing them to cross over from the right side.
Clever.
It is. Echo can also pick up other things, like abnormal motion of the septum between the ventricles or dilation of the pulmonary artery, which can give clues about the severity and pressure changes.
So echo is really the key diagnostic. Are there any other, maybe even more specialized tests used sometimes?
Occasionally, yes. For really complex cases or maybe larger ASDs where you need precise measurements, cardiac catheterization might be considered.
Sounds invasive.
It is more invasive, yeah. It involves feeding catheters into the heart chambers and major vessels to directly measure the pressures and the oxygen levels in the blood in different places. It gives very detailed information, but it's not routine.
Right.
And sometimes if there's a suspicion of intermittent arrhythmias, like occasional skipped beats or short bursts of AFib that aren't showing up on a regular resting ECG, a vet might recommend 24-hour Holter monitoring. The horse wears a portable ECG recorder for a day to try and catch those episodes.
Okay, got it. So let's shift gears. Once you have that diagnosis, maybe via echo, what does it all mean? What are the treatment options for a horse with an ASD? And the big question is surgery an option, like it often is for kids or adults?
Yeah, that's a really critical point, and it's where things are quite different for horses compared to humans or even dogs. Let's break it down. For horses with those small asymptomatic defects.
The ones found by chance.
Exactly. Most of those actually require no treatment at all. The recommendation is usually just monitoring maybe an annual echocardiogram to make sure nothing's changing significantly.
And they can live normally.
Many of them, yes. They can live a normal lifespan, have a good quality of life, and many can even perform athletically, potentially even at upper levels with no restrictions.
That's good news for the small ones.
Yeah.
What about the ones causing problems, the symptomatic ones, or those developing CHF?
Right. If a horse has a larger defect that's causing symptoms, or if it develops congestive heart failure, then treatment becomes necessary. But it's primarily palliative. Meaning it's focused on managing the signs of heart failure, improving quality of life, rather than fixing the underlying hole.
Okay. What does that involve?
Usually medications. Things like diuretics furosemide is a common one to help get rid of excess fluid buildup. Sometimes vasodilators or ACE inhibitors like enalapril or benazepril might be used to try and reduce the workload on the heart.
Any drugs to make the heartbeat stronger?
Positive inotropic drugs like digoxin. They are used much less commonly in horses than in small animals or humans for heart failure. There might be specific situations, like if the horse also has AFib with a very fast heart rate, but generally they aren't a mainstay for ASD-related CHF in horses.
Okay, so mostly managing symptoms with meds. Now, back to that surgery question. Fixing the hole.
Yeah, this is the key difference. Surgical or even interventional closure procedures, things like using catheters to place devices to plug the hole, which are quite common in human medicine.
Right, the umbrella devices are similar.
Exactly those. Those procedures are not routinely performed or considered practical in horses.
Why not?
Several reasons. The sheer size of the animal makes everything much more challenging and requires specialized, large-scale equipment that often isn't readily available. The procedures themselves are highly invasive for a horse.
And cost, I imagine.
Huge cost, yes. And frankly, there's a lack of widespread specialized expertise for performing these complex cardiac interventions routinely in horses. So the bottom line is surgical or device closure just isn't a financially feasible or practical option for the vast majority of equine patients, especially if the goal is athletic performance. It's just not something that's really done.
That's a really crucial distinction for owners to understand.
Yeah.
Very different from the human side.
Absolutely critical.
So, given that treatment is mostly monitoring or palliative care, what does that mean for the horse's activity level? What are the guidelines, and what do owners need to watch out for?
Good question. For those horses with the small asymptomatic defects, activity is generally unrestricted. As we said, they can often compete successfully.
Okay.
For horses with defects that are considered hemodynamically significant, meaning the shunt is big enough to actually affect blood flow dynamics significantly.
Right.
Lower level athletic competition might still be possible, but it's really important they have regular, typically annual echocardiographic monitoring to ensure it's safe and things aren't progressing.
And if things get worse, like that leaky valve or AFib you mentioned?
Yeah, if a horse develops significant tricuspid regurgitation or goes into atrial fibrillation or shows significant dilation of the pulmonary artery on echo, at that point, it's generally considered no longer safe for them to be used for full athletic work or even strenuous riding. The risks become too high.
Makes sense. What about general owner education? What should they be watching for day to day?
Vigilance is key. Owners need to be educated to regularly monitor their horse's resting heart rate and rhythm. Any sustained fast rate or obvious irregularities beyond maybe the occasional normal dropped beat a horse can have should definitely trigger a call to the vet for an ECG. And they need to be sharp-eyed for any new signs developing. Things like sudden exercise intolerance, any signs of respiratory distress, faster breathing, difficulty breathing, coughing, an increased resting heart rate or breathing rate that persists, seeing those jugular pulses become obvious again, or noticing new swelling under the belly or in the limbs.
Any of those signs mean?
Any of those signs warrant an immediate re-examination by their veterinarian. It could mean the condition is progressing or heart failure is developing.
Got it. Okay, the final big question then. What's the prognosis? What's the long-term outlook for a horse diagnosed with an ASD?
Well, like everything else with ASDs, it really depends heavily on the size of the defect and whether complications develop.
So for the small ones again?
For horses with small defects, the prognosis is generally excellent. Normal life expectancy, normal performance life is entirely possible.
Okay, that's reassuring.
Yeah.
Moderate ones.
With moderate defects, they also tend to have a normal life expectancy. However, their athletic career is often limited, usually successful only at lower levels of competition. And they do have a higher risk of developing atrial fibrillation later on.
And the large defects.
Horses with large defects have a more guarded prognosis. Their lifespan might be shortened, and their performance life is likely limited, even potentially at lower levels. They're just dealing with a much bigger cardiac load.
Right. And if CHF develops?
The development of congestive heart failure unfortunately carries a guarded to grave prognosis. While the palliative treatments we talked about can provide some temporary improvement and comfort, once CHF is established, long-term survival is poor. Euthanasia is, sadly, often the most humane recommendation at that stage.
That's tough.
It is. Similarly, if the horse develops significant pulmonary hypertension, high blood pressure in the lungs due to the shunt or persistent arrhythmias like AFib, those also indicate a poor prognosis.
And what about foals diagnosed very early?
Generally, foals that show severe clinical signs very early in life tend to have a poorer prognosis overall. It often suggests a larger, more significant defect right from the start.
Okay. So quite a range in outlook depending on the specific.
It's very wide range, yes.
Right. So just to quickly summarize them, atrial septal defects in horses, they're congenital holes in the heart wall. They vary massively in severity, from being totally insignificant found by chance to causing severe heart failure. Definitive diagnosis really hinges on echocardiography, that cardiac ultrasound.
Absolutely.
And management is quite different from humans. It's mostly about careful monitoring for the small ones or palliative care to manage symptoms for the larger or complicated ones, because surgical correction just isn't a routine or practical option for horses.
That sums it up nicely. And, you know, this whole deep dive into ASDs, it really underscores this interesting intersection in large animal medicine. We have these advanced diagnostic tools like echocardiography, but we also face very real practical limitations when it comes to intervention, especially compared to human medicine.
Yeah, that's a great point.
It really raises a question, doesn't it? Considering how much the defect size impacts the horse's entire life and potential, and knowing the treatment options are limited, what does this tell us about the balance we strike? The decisions owners and vets face. You know, for you listening, if you were faced with this kind of diagnosis in an animal you care for, what factors would you weigh most heavily, knowing this mix of hope, realism, and the unique challenges of equine cardiology? Something to think about.